Good morning or good day. Thank you again. My name is Deborah Levine, and I am the director of the Harlem Health Initiative for the CUNY School of Public Health and Health Policy. It gives me great pleasure today as we launch our skills building webinar series, COVID-19 and the Political Economics Part 2, Investing in Our Collective Future. It gives me great pleasure to bring forward Dr. Moon and Dr. Bailey, who will lead us through this conversation and presentation. We will also follow this up with a question and answer period. So please feel free to use the chat. And we look forward to an exciting presentation and a great question and answer conversation. At the end of this, you will also receive a link. This webinar is being recorded, and it is also on our Facebook Live page at the Harlem Health Initiative. So thank you very much, and I will turn the floor over to Dr. Moon and Dr. Bailey. Thank you again.
Hello, everyone. Hello, Harlem Health Initiative. My great colleague and friend, Dr. Zinzi Bailey, is here with me to present our part 2 of this two-part series of the COVID-19 and political economy paper we've written. Oops. We will get coordinated, I promise, in a second. Okay, just quick number. We always have to have the tallies of the numbers. So multiple variants later, these are the confirmed cases as of yesterday, globally in the US. I'm going to make one point. US accounts for 4% about of the world population. And we also at the same time account for 18% and 15% respectively of the world numbers of confirmed cases and deaths. So that's just to highlight the disparities that we experience here. And this number, 18 and 15, has not changed very much pre-vaccine and now. So but pre-vaccine, it was something like 20% and 16%. So that has not changed a lot.
And so as we've been dealing with COVID-19 for the last 2 years, among many different things, COVID-19 has been laying bare the structural inequities that create very different conditions across different populations in which we live. So particularly highlighted in our previous work, historical and contemporary racism and racialized decisions around the American social safety net have driven the distribution of health and disease that we see across populations and have set the stage for structural vulnerabilities in health, right? And I think we can see that through numerous graphics that we're going to be showing you today. It has been very important throughout this pandemic to recognize that Black, Indigenous, and other people of color are overrepresented in racially and economically segregated communities that often have substandard housing conditions or unsafe or limited water, crowded housing conditions that make hand hygiene, self-quarantine, self-isolation or, social distancing challenging, if not impossible. And we can think about, even now, Flint, Michigan, thinking about the safety of their water. And then earlier this year, thinking of people in Jackson, Mississippi, in which a winter storm was able to knock out a great proportion of the potable water to most of the neighborhoods. And furthermore, especially earlier in the pandemic, although it was not always luxurious, staying at home in self-isolation was a luxury for some and not others. And so as we move towards testing and vaccination, other inequities have also revealed themselves. In this particular graphic, it displays incident deaths due to COVID per 100,000 over the course of the pandemic, right? So this is the last 2 years, right? We see early in the pandemic a sharp peak for Black, non-Hispanic, and to a certain extent Hispanic populations, right? Before the curve starts to come down for everyone, except for some sustained level of deaths amongst the American Indian Alaska Native population until late summer, right? Before a winter surge with American Indian and Alaska Native populations with the highest rates, right? Our latest surges also show American Indian and Alaska Natives at the highest levels, followed by non-Hispanic Blacks and more recently, non-Hispanic whites. In the United States, when we're talking about structural inequities and those sorts of things, race is our primary lens for looking at that. You know, obviously this is an idea that is, you know, we're still talking about intersectional ways of looking at this, but most assessments of our inequities in this country are incomplete without looking at race. But when looking at any kind of data like this, everybody brings their own personal biases or disciplinary biases based on what they've been socialized to believe. So we often think about what we saw earlier in the pandemic. So initially, when we're talking about the narrative and the science, it was centered on race and ethnicity as being risk factors for severe disease, but primarily through these so-called underlying conditions and genetic arguments, which we argue is not at the heart of the story, right? We might be talking about those factors, but this is a very surface kind of description of where we are and what might be causing disparities in health. So this potential biology and chronic disease was emphasized rather than highlighting the fact that the essential workers with the most frequent proximity to others are also the ones that are less visible. They're not like doctors and firefighters in the limelight, and they're more likely to be low-wage workers of color. And so over time, you know, our social justice warriors have been alert, right, and have shown up to highlight the pre-existing underlying pandemic of structural racism. So highlighting that race is not the cause, but racism is. Right? So COVID-19 is not spreading over a level playing field. Racism has been embedded in our very social fabric through our infrastructure investments, our public policy, and it drives our health inequities. And then when we look at such proximal factors as thinking about chronic conditions, right, we must couch this within an overarching, the overarching social and political landscape and ask, what is also driving disproportionate rates of chronic disease? Here, we can see a matrix of colors representing overlapping baseline factors from like around 2018, and essentially between coronary heart disease and hypertension hospitalization, and on the other end, populations without insurance by county, with some of the most structurally vulnerable locations being located in the South and the Rust Belt, right? Counties in the South have high rates of hospitalizations and moderate proportions of the population without health insurance. Meanwhile, counties in the West have lower rates of hospitalizations as well as lower rates of uninsured. It's important to note that 40 counties, 2/3 of which are in Texas, have both high coronary heart disease and hypertension hospitalization rates and a high proportion of uninsured. So what we're seeing is essentially an overlapping of the different kinds of inequities or structural vulnerabilities that are the initial landscape for COVID-19. As we go on, we also must think about the fact that Black, Indigenous, and people of color experience structural barriers to healthcare access as well, including residing in states with no Medicaid expansion, drastic cuts to public health infrastructure, and the unraveling of our national safety net, right? So where this map depicts where Black populations live, aged 0 to 64. And you can see that there's a heavy concentration in the South, but more particularly that it's that these populations are concentrated in a number of states that do not have Medicaid expansion. This creates a structural vulnerability.
So we talked last time in the part 1, we've seen this map as well. Maps tell great stories. Before we move on to this particular example in New York City, where we are, where you guys are, we're talking about social determinants of health versus social determinants of health equity. We are going to keep on making the distinction between the two and how they're related, but they're not the same thing. And the Medicaid expansion map you just looked at is a social determinants of health equity example. So here too, so now we're looking at these 4 maps. They're essentially just different color coded, but it's kind of the same thing. Roughly, if you look at the darkness, the darker the color is, the higher the burden, whichever direction. So for example, the first map here in the upper left-hand corner, number of positive cases, right? So COVID cases overlaps with the number, the concentration of service workers, people of color, and rent burden, meaning people have struggles of paying rent on time. So they kind of, I could have, scrambled this map and put different labels, but they all basically look the same thing. Look like the same thing. So this disproportionate impact of the COVID-19 pandemic looks like this. And this one I also touched on the last talk. So New York Times early on 2020 had this article basically talking about the very proximal, high exposure and people with pre-existing conditions, they're concentrated in the Bronx, but it doesn't really necessarily talk about why social determinants of health equity and how it goes all the way back to the structural vulnerability and marginalization that the residents of certain parts of the Bronx had to experience. So that does not tell a full story. And here we keep on going back to telling the full story, giving a full context from the past to the present.
And as we're emphasizing and re-emphasizing this historical context and essentially the playing field and how not level it is, people might ask, why does this distinction between those drivers, those immediate drivers and context matter? And so for me, I try to go by the words of Martin Luther King Jr., said that the prescription for the cure rests in the accurate diagnosis of the disease. So if we're only going after those chronic diseases and those sorts of things, we are missing everything upstream of that, which are really driving those differential rates of chronic disease. So we can think about the holes in the playing field, right, that make it not level, and that those holes are burdening key populations. We often talk about racial and ethnic minorities, or rather marginalized populations. So Black, Latinx, Asian, Indigenous. We're talking about poor people, so people living in poverty, elderly, right? People living in rural or frontier areas, people who are experiencing homelessness, right? Essential and frontline workers, which are still, it's still at play right now. People with disabilities, right? This is something, as we are changing and trying to go back to some level of normal, quote unquote, there are people who are left out. And I have a particular interest in the people who are justice involved, the incarcerated, right? So I think we go back and forth as to whether we're caring about the incarcerated through this pandemic. But there is a very opaque data systems within our jail and prison populations for detecting COVID or for reporting out COVID and deaths and what is actually being done in each place, right? And then we can also think about non-US born persons or migrants, right? All of these folks are experiencing structural vulnerabilities that are driven by structural violence, right? And structural racism. And so these holes in the playing field are demonstrations of structural violence and structural racism, and they produce these structural vulnerabilities, right? So what is structural violence? Structural violence is a form of violence in which some social structure or structures, right, or institutions may harm people by preventing them from meeting their basic needs, including the prevention of acute illness, right? And then that structural vulnerability that comes from that is the risk that an individual experiences as a result of that structural violence, including their location in multiple socioeconomic hierarchies. So when we talk about thinking about health equity and reducing inequities, we have to think about health equity being achieved when every person has the opportunity to attain his or her or their full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. So health inequities are reflected in those kind of things on the right-hand side of this graphic, right? The right-hand side is looking at differences in length of life, in quality of life, in rates of disease, disability, and death, severity of disease, access to treatment. But this doesn't mean that health equity is simply the inverse of those things on the right, right? Health equity looks like not only like equality in outcomes, but also equity in the process. So interventions addressing health inequities can be conceptualized as occurring upstream, downstream, somewhere in between, and most are somewhere in between. But those downstream determinants occur on the individual level, most likely, right? Including individual biology and specific risk factors and behaviors. Intervening on that level will help individuals, especially perhaps in the clinical context, but it does not address the factors upstream that are driving the patterns that you're going to see, read inequities, in health behaviors, outcomes, and biology. So if we're going further upstream, we can find living conditions, which include physical, residential conditions, social environments, work environments, service environments. So if we think about a residential environment, if a child lives in public housing that is under-resourced to address common pests, that child is more likely to encounter asthma attacks or require emergency department care or hospitalization. And oftentimes we call that social determinants of health. And we can intervene on these social determinants of health. We can intervene on remediating one apartment or home, or increasing access to insurance, right? However, this is not going to get at systemic reasons by which public housing translates to poor built environments and by which that family needs public housing in the first place. So the question is, why are certain living conditions more prevalent among certain populations and not others, right? And often we see institutional inequities in the public and private sectors, as well as public policy driving this distribution of social determinants of health. Resource allocation for public housing and the absence of universal access to a living wage might be driving the living conditions within public housing. However, we need to go further upstream to the social determinants of health inequities, like racism, sexism, thinking about these systems of social inequities like racism, sexism, classism, heterosexism, ableism, to see how access to resources and healthy living conditions are inequitably allocated or distributed, especially institutionally, across pre-existing hierarchies of power.
One second. So where this box here all the way on the right side is something like 90+% of our healthcare investment nationally goes into where 90% plus reasons for why health inequities are happening is in the upstream, all the way in the social inequities and institutional inequities. So there's a mismatch, a great mismatch in lopsided investment in our health and well-being.
And in order to sustainably drive towards health equity, we have to be thinking about the ways to improve our communities further upstream. So if we're only working downstream, then we're not thinking about those larger structures. we're not going to have sustainable change. And furthermore, we might be victim blaming, right? Or trying to get a response that's not going to happen unless we're dealing with the root causes of health inequities. So thinking about structural racism and structural violence, so structural racism more specifically and structural violence more generally, they're not caused by, nor can they be repaired solely by individual agency and behaviors, right? We have to take a collective approach to dismantling these systems of inequity. And so here we realized through this pandemic that we needed to be more specific about that.
So the first paper we wrote, which I presented at the part 1 of the series, was on structural racism, and how using the case study of the Bronx and how the great disparities in the COVID outcome that we have seen. There's a reason in history. There's a context that brings us to where we are. So in the second paper, we call it our sequel paper on American Federation of Teachers. There's a link at the bottom, which is I assume that you guys have seen this about this this talk, but that's free, open access to everyone. We wrote a paper to talk more broadly about, of course, that structural racism and violence is bookended by white, Black racism, but there's all other colors in between. So BIPOC, as we talk about, all of us involved, and in our society is involved in this, and that comes from our history to the present day. So this paper encompasses all of those, things like racial capitalism, and within the context of structural racism. So we're going to talk about that today. So some of the most prominent indicators of our health and well-being is life expectancy, and we Americans, we pride ourselves in at what we used to on having this American dream, achievable American dream, and this. These graphics by Chetty et al. At Harvard depicts the American dream as we know it has been fading. So the trend in absolute income mobility. So American dream promises the hard work and opportunity will lend to a better life. So the harder you work, the better opportunity, more opportunity you will get, is basically how we understand it. My family came from South Korea when I was younger with that American dream. A lot of us, and your family too, from Jamaica. So on the left-hand side, this graphic shows, so in the 1940s, 92% of the children had a better income, better life in terms of income mobility than their parents' generation. And come 1950s, 1960s, and 70s and 80s, by the 1980s, only 40%, 40%, I think almost exactly, of the children had better income mobility than their parents. So 92 to 40, that's a huge stark comparison. And if you look at the right-hand side graphic, this is showing the rates of absolute mobility by cohort. So, the birth cohort. So from 1940s all the way to 1980s, look at how it goes from 92. It's just a different way of depicting what's on the left side. 92% all the way down to 40%. So American dream, does it exist? Maybe, perhaps for some, but it seems largely to not be working for a lot of us. And growing socioeconomic disparity. So net productivity, so Americans are working very hard as a whole. Net productivity in this country has risen by 72%, while the hourly pay of typical workers would be, what we would call, blue collar or essential workers, it only increased by 17%. So where did that, what's the difference? How do we explain this difference? And people at or below the median income saw their income rise only by 1% or less every year. And if you go to the last bullet, the top 1%, so that's defined by adults receiving average of 1.31 million a year, saw dramatic growth in their income after 1980s up to 6%. So so we're talking about increasing disparities. So and at the very bottom of the of our population, some people have seen income even fall pre-tax, less than we used to make. And government assistance program like food stamps and earned income tax credit and things like that have also failed to reach up to 1/4 of those people who, the programs are intended to help. So in a nutshell, we're talking about U.S. economy growing greatly in the last 40 years, while the income disparity has been also proportionally getting bigger. Some people do better than others, simply put. So, and then there's a racial patterning of such socioeconomic disparities we see. So in the last 40 years or so, Black Americans, Native Americans have experienced lower rates of upward mobility in terms of income mobility from parent generation to children generation, as we saw, and higher rates of downward mobility. So it's a double-edged sword. It's not just lowering the slowing the upward mobility, but downward mobility has gotten picked up its pace. It's largely driven by differences in wages and employment among men. This is all after controlling for everyone with the parental income being equal. So that's the number we're talking about. And traditionally hypothesized in drivers like wealth, education, background, the socioeconomic stuff, right? And the marital status turns out that they explain very little of such difference, the socioeconomic mobility between Black and white Americans. So we're talking about race being the factor here. And in terms of income and wealth, so there's a huge difference by skin color in terms of our income and wealth disparity. So as of 2018, for every $1 the white households earned, we're talking about income here, 59%. So less than 60% of that was went to Blacks and Native American population, and 72 cents of that went to Latinx. This is this income gap, by the way, by race is the same as 1978. That's not a typo. That is 40 plus years ago. So our income disparity among racial groups has not changed. And wealth, picture of the wealth is even worse. For every dollar wealth, so wealth is the accumulated asset, right? Savings and safety net. And that had a huge role during the COVID-19 pandemic, especially when one lost jobs and, we couldn't work because of the pandemic situation. So, if you have no safety net, no savings in bank account, that's the wealth we're talking about. So every dollar of wealth, the white households have, Black households have 10 cents, that's 10%. And Latinx, 12 cents, 12%. So in the absence of public investment, which we lack a lot, Americans relied on privatized, individualized financial safety net. So, your own savings. So, lacking the public investment in the emergency situations such as pandemic, we have seen such great suffering because it's unequally distributed access to the households reserves to cushion the shortfalls of income. And I think this is something that we're all familiar with by now. Quickly, life expectancy, another prominent measure of health and well-being. So this is a very recent paper. So life expectancy at birth in the U.S. by race and ethnicity, as you can see, the U.S. Where's U.S.? U.S. is yellow, and I can't even say that. And then peer countries above. Look at the disparity, the difference between that gap. So we have, 1.88 years of life expectancy gap between the U.S. and the peer countries. So if you see the map since the graphic since 2010, we have been slowing down in the increase of life expectancy as a country. And then it was starting to decrease already pre-pandemic. And then since the pandemic, there's a very sharp decrease in life expectancy. I'm driving this. So it actually decreased from 2014 to 2018 for all racial groups, but we will show on the next slide, that there's difference by racial groups. The decrease in life expectancy between 2018 and 2020 was 1.9 years or 1.88 years. That's 8.5 times the average decrease in other peer countries. And the numbers are even starker in Hispanic population and non-Hispanic Black population compared to the respective peer countries. Life expectancy since 2018 decreased by 18 times for Latinx and 15 times for non-Hispanic Blacks respectively. So that's a really shocking number, but is that really shocking? I think that it's also, we could argue, especially the public health folks here, it's been highly predictable, and we've already been showing data on that. Our social contract has been deteriorating for decades. So all the more importance of visiting back the context as to why we got here.
And so guided by a public health and critical race praxis and eco-social theory, when thinking about the relationship or racism in relationship to health equity in the United States right now, we still need to be thinking about these questions stimulated from the public health and critical race praxis, right? How is racialization relevant to this problem, right? And how is racialization relevant to the production of knowledge about the problem? And I think we are at a critical nexus for essentially bringing that out, right? So for us to be investing and thinking about racialization, allowing us to think about all the processes that led to the racial groups that we have here, and the processes by which we, have these racial and ethnic groups that seem relevant, right? In regards to health and how health is distributed. And then thinking about what information is missing from what we have access to in public health literature, in economic literature, et cetera, right? So we can be thinking about that. And oftentimes when I talk about racialization in public health spaces, especially epidemiological spaces, people are talking about, they ask, what is racialization? So much of our research in public health especially has focused on race and causation, implicitly or explicitly relying on racial essentialism. So thinking about the idea that differences between different racial groups, right, are fixed and uniform and often, equated or conflated with biology and ancestry. And this has led many to consider race as this kind of immutable, unchangeable characteristic in, the data, right? Like, we can't do anything about it, right? So there's differences in race and we can't do anything about it. But what is important is that race is a social construct. So through racialization, distinctions between races and the importance of phenotypic and genetic factors are driven by cultural, historical, ideological, geographical, and legal influences. And that racialization produces these racial categories that are, inherently hierarchical to one another, right? And so in that, race derives its meaning from the differentiation of groups, not from the precise measure of any kind of characteristic associated with that group, right? So essentially, we need to be thinking about that racialization and those processes as normative in society and permeating all aspects of life. Furthermore, race then operates as a marker of that kind of long process of racialization, right? And it becomes salient because of society-specific and time-specific racialization, which applies to a range of groups that have been racialized over time. And so again, that shortcut to explaining these processes of racialization is simply to say that race is a social construct. And so those same processes of racialization we must think about are rooted in racism, our experiences of racism, right? And it's important to think that racism is not a collection of isolated acts, right, that are bundled together. Racism is an organized social system in which The dominant racial group, based on ideology of inferiority, categorizes and ranks people into social groups called races and uses its power to devalue, disempower, and differentially allocate valued societal resources and opportunities to groups defined as inferior. And so we can also think about racism in some non-exhaustive levels, right? Internalized racism really occurring within an individual in the form of an internalized, often implicit sense of superiority or inferiority. And then we can think about interpersonal racism. And interpersonal racism is often what we commonly think about as racism. When you say racism, you think about interpersonal racism, which is occurring between individuals. And it comes in the form of intentional or unintentional discriminatory acts of omission, so not providing service, or commission, direct acts that are based on prejudice. And this takes the form of hate crimes, clutching one's purse, crossing the street, or providing poor service. Institutional racism, on the other hand, occurs within and between institutions through discriminatory treatment, practices, and policies that then result in inequitable opportunities and impacts for marginalized, racialized groups. And of particular interest to us has been, is structural racism, which can be referred to as a totality of ways in which societies foster racial discrimination. And they do that through, mutually reinforcing systems of housing, education, employment, earnings, benefits, credit, media, healthcare, criminal justice, the list goes on. And that in turn reinforce discriminatory beliefs, values, and distribution of resources, and is reflected in our history, our culture, and our interconnected institutions. Furthermore, structural racism normalizes and legitimizes adverse outcomes for people of color. So if we think back to the graphic that Robin shared with us, we can see that, while we are looking at that difference in health from our, in life expectancy from our peer nations, the differences for Black and Hispanic, Latinx, or Native American groups have been kind of normalized. We're like, okay, it's bad, but we're not really that alarmed. But when we saw a drastic, we see the decline for whites, it is all hands on deck situation, right? So not saying that we're not weighing deaths and all these things, but what we're saying is that there's a normalization of, adverse outcomes for people of color, right? And so structural racism operates through these other forms of racism and through key pathways, including inequities and social determinants of health, to produce inequities in health by racialized group, right? And these pathways could include such things as economic injustice and social deprivation, environmental and occupational health inequities. We've seen that a lot through the pandemic. Psychosocial trauma, state-sanctioned violence and forced displacement, political exclusion. So a range of different factors, right? And structural racism is manifested in particular policies, practices, and programs that work to segregate populations and create barriers to social opportunity and upward mobility. Residential segregation has been one of the clearest instances of racist violent policy that sets the stage for a vast system of structural racism, right? It sets the stage for colorblind distribution of resources over time through environmental hazards, through inadequate healthcare, inadequate education, state-sanctioned violence, and municipal disinvestment, those pathways, right? So we can think about through structural racism, redlining and benign neglect being coupled with the discriminatory impact of the Social Security Act, unfair school funding based on property taxes, for example, and concentrated policing across generations over the life course and across domains to produce differential intergenerational wealth education, income, exposure to concentrated poverty, and exposure to quality hospitals, schools, and jobs. So essentially, there's a differential way of or access to quality healthcare, education, employment, all of these key things, key domains for having opportunities in life, right? We can think historically about the New Deal era, right? The 1930s, largely 1933 to 39. And we can think about the vision of the American people, right? So we put in a lot of different policies to essentially open up opportunities for people, right? But when we were doing that, when we're putting the Social Security Act of 1935 into place, the vision of the American people was white people, right? Mostly white dominant, right? And so the Social Security Act of 1935 explicitly excluded farm workers and domestic workers, occupations that were primarily held by Black people. And so that denied access to generations of Black people. They denied them the access to old age and unemployment insurance. What does that do to wealth? That is what we're talking about. We can also speed up and think about kind of the 1946 Hill-Burton Act, you know, kind of stemming from, you know, some of our old separate but equal kind of legislation, but it set the stage for kind of unequal access to quality healthcare, right? Thinking about Medicare and Medicaid, right? So it's not until the Social Security Amendments of 1965 that it essentially forced hospitals, medical centers to integrate racially and ethnically, right? Conforming to Title VI of the 1964 Civil Rights Act, and improving healthcare access and health outcomes for Black people for generations. So there's a range of different studies that have demonstrated that. So prior to that, we're talking about allowing for a completely segregated system with different quality of care, right? And that being legally binding. That was the law of the land. And it took legislative practices, legislative changes in order to essentially correct that, right? And so following the legislative changes, we've seen that Black infant mortality fell precipitously, especially in former Jim Crow states. And so furthermore, if we fast forward again, we can think about Black-white disparities in premature health or premature death and infant mortality decreasing between 1966, so post the Civil Rights Act, to 1980. So where some specific things happened in 1980, right? Or, you know, in the 80s, right? It began to rise again in the 80s during a time of neoliberal erosions of the social safety net. If we think about, you know, Reagan's characterization and narrative around welfare queens and allowing that racialized dynamic to destroy and dismantle our American social safety net. You can also, you know, see the normalization of adverse outcomes for people of color and the fostering of racial discrimination through mutually reinforcing systems by comparing our society's dramatically different reactions to the crack, read Black, versus opioid white epidemics. So those are the large characterizations, especially in media and different pundits, right? And so essentially modern drug policy has to go back at least to the 60s and 70s, where there was a rise in drug use, first associated with like a hippie lifestyle and the return of Vietnam veterans who were exposed to heroin abroad, disinvested and segregated neighborhoods. And in 1971, Nixon declared a war on drugs. So essentially drug abuse being that public enemy number one, right? So with that, essentially there was a portrayal of who was using drugs and who was driving that epidemic, right? And despite divergent demographics with actual drug use, the portrayal of drug use was racialized, right? As a problem for urban Black and Latinx communities. It was framed as a pathology that needed to be rooted out and criminalized, right? This drove a long-standing commitment to aggressive policing and mechanisms of law enforcement, particularly in Black and Latinx communities, whereas white users were considered innocent victims of Black and Latinx pushers, the traffickers, who were infiltrating their neighborhoods, right? So during this time, the DEA was formed, the Controlled Substances Act was enacted, and other policy and rhetoric inspired Rockefeller laws, including the idea of mandatory minimum sentences, right? However, all of this was racialized in enforcement. In a 1994 interview with Nixon's domestic policy advisor, Ehrlichman, in what was likely to be a simplification of the time, but he said, the Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and Black people. You understand what I'm saying? We knew we couldn't make it illegal to either be against the war or Blacks. But by getting the public to associate the hippies with marijuana and Blacks with heroin and criminalizing both heavily, we could disrupt these communities, and disrupt them they did, right? Fast forward to the 1980s when crack cocaine made its way onto urban streets. So while crack wasn't relegated solely to urban Black and Latinx communities, the narrative around the crack epidemic was one of Black and Latinx men as gang members, as fiends, as predators who deserve to be punished, and Black and Latinx mothers whose pathological addiction damned their children to a life of permanent disadvantage. That was the image that was brought up, right? These permanent intrinsic differences that and the terms crack babies or crack kids were constantly thrown around, that it became something inherent to who these folks were, right? And this became the new front on the war on drugs and drove a lot of mass incarceration, concentrated specifically in Black and Latinx communities. At the same time, Wall Street professionals, Hollywood types, different folks, they were infamous for using powder cocaine, but rarely faced consequences. So there's no real difference between cocaine and crack, which makes the racial nature of the so-called war on drugs especially clear.
Crack was just cheaper.
Exactly, right? So under the Anti-Drug Abuse Act of 1986, the distribution of just 5 grams of crack carried a minimum federal prison sentence of 5 years compared to 500 grams of powder cocaine for the same sentence. So essentially, it's a ratio of 100 to 1. And the only real difference between crack and powder cocaine was that it was cheaper, right? Exactly what Robin said. It was more accessible to poor Americans, especially, let's say, Black Americans in a segregated neighborhood suffering from decades of disinvestment, right? This legacy has forced generations of Black and Latinx Americans to be disproportionately caged in the United States. So this disproportionate policing, sentencing, and prosecuting of Black and Latinx folks has led to an exponential rise in incarceration, which is just beginning to kind of level off, right? In 2003, perhaps at the height of mass incarceration, more than 66% of crack users were white or Hispanic Latinx, but they made up only about 18% of the defendants sentenced under harsh federal sentencing laws, while Black people made up a whopping 81%, right? The impacts of this disproportionate enforcement of inequitable laws have been not just limited to those who are locked up. It has had devastating impacts on families and communities. They've been torn apart, just as Nixon was really intending, right? It just took it a little bit longer to be enacted. So let's put that in contrast to the opioid crisis, which is we are in a real debacle, right? But there is a change in how we are approaching it, and a change in narrative, right? A change in direction enough to create some kind of cognitive whiplash, right? And so with the opioid crisis, in contrast, the narrative centers around mostly rural and suburban white Americans preyed on by evil, greedy pharmaceutical companies, and has led to lawsuits, right? Some of which have been, somewhat settled. And suddenly those symptoms of criminality that previously deserved hard punishment were considered as human beings with a soul, right? In a federal hearing in July 2017, we hear Virginia's Secretary of Public Safety and Homeland Security saying, we cannot arrest our way out of the heroin and opioid addiction crisis, right? This is very different than what we saw before with the crack epidemic, right? A lot of the opioid deaths are associated with deaths of despair, right? Gun-related suicides, drug overdoses, alcohol-related deaths, and more than likely, or more disproportionately among less than college educated whites in their middle age, right? And it's linked to, they're linked to rhetorically to places where manufacturing and other blue collar jobs really disappeared, right? So where communities that were formerly supported by industries, by different companies that were, located there, and they're experiencing the high social costs associated with that loss of industry, right? And that loss of purposeful employment and hope more generally has been seen as part of that explanation of both addiction and mortality. But it is important to note that these are the same mechanisms that were at play previously in the previous example in the crack epidemic and segregated, disinvested neighborhoods. What is a segregated or disinvested neighborhood but a place that lacks hope? There is a loss of purposeful employment. There's a number of different factors that we can be talking about. And addiction is a behavioral health issue that rears its head wherever there's a loss of purpose, hope, regardless of race or ethnicity. What we're seeing are very similar factors, right? And so not only that, we can also think, if we put aside the whole culture of poverty situation, we can think about 2 decades before that the conceptualization of, before these deaths of despair, the renowned Black sociologist, William Julius Wilson, described a similar connection between decline of work and opportunities in urban Black communities and the rise of health and social issues. Yet, economic shifts themselves did not necessarily lead to despair. It's the combination of economic change and the lack of public goods to be a social resource to buffer some of those changes, right? So we have the opportunity for us. Economic change or systems of change are not synonymous with despair, right? There is a way that we can be investing in our collective future, collective goods, in order to then bolster our whole society. So together, what these results are telling us is that we need to be thinking about our whole society and thinking about who are being systematically excluded, especially in a racialized way, but where there's impacts for quite a number of us.
So that's the first of the 2 case studies in our paper, the racialized drug policy. And the second case study in this paper, we talk about racialized value of labor and the concept of racial capitalism. So racial capitalism, in simply put, our capitalist society is built on racism, starting with our African slavery, right? So like literally those humans of different colors, darker colors, were sold for money, and they were enslaved. And to the current day, there are different levels and kinds of indentured servant servanthood that we have been seeing in the, I know it's not just in this country, but the start where the racial capitalism's stark example can be portrayed here. And that's in the same rubric and same landscape of structural racism and white supremacy. So we make a case study of Filipino nurses. So Filipinos, just to put it into context, Filipino population in the US comprise 1.1 of our total population. 4% of the US nursing workforce is Filipinos, specifically Filipino women. And however, 25% of all COVID-related deaths by essential workers, among nurses specifically, were born by Filipino nurses. So going back to history, at the turn of the 20th century, Spanish-American War, Cuban crisis, right? So, before Cuban crisis started, the Cuba and a number of Caribbean countries being under the Spanish rule, US got into the Spanish-American War, and coming out of that war, so, Puerto Rico, Guam, and the Philippines, among some other countries, have become came under the US. So the terms like benevolent assimilation, as in, we are doing this loft mission of helping these uncivilized and barbaric population to assimilate to the civilized and educated and, cleaner, healthier society. So that's a benevolent assimilation, is a term specifically used on the Philippines and the Filipino population by President McKinley. And white man's burden, the famous phrase that we know of, was also specifically for this Philippine annexation to the US. The American missionaries and American nursing schools went into the Philippines, and we trained a great number of Filipino women to be nurses. So, they got jobs through that Americanized training in English. The post-war, post-Spanish and American War needs for the nurses, and fast forward for our Medicaid and Medicare creation in the 1960s, there's a big job opportunities, workforce opportunities for them to come to the US. And then the preferential migration laws, such as Hart-Celler Act of 1964, had given preferential access to the Filipinos, Filipino nurses, among others, some other Asian immigrants to come to the US. So, by the 70s, there was 150,000 Filipino nurses in the US working, and they are also portrayed by this term, grateful immigrants. They were placed in the most precarious, most prolonged risk environment, and they culturally, and because of their this historical context, they're always grateful to have the opportunity to keep their jobs, and they do not say no. So the concept of grateful immigrants have come all the way to the present day during the COVID pandemic, and that has that explains a lot of why 25% of all COVID-related deaths were among Filipino nurses when they only make up 44% of the U.S. nursing workforce. Before we talk about the Filipino population, there's a greater context to the Asian migration. So before Asian migration, there's also this country started on with the British and English rather, and then East European immigrants, depending on the skin color. There has been different values put on, placed on these populations, in terms of what, the profession they had, the modes of working. Asian migration history shows from, 1875, Asians were the first immigrant group to be barred, from coming into this country based on a number of different unfounded reasoning, and all the way to 1924, there are different exclusionary acts by legislation. The Asians were barred. So then with the preferential migration policy for populations like Filipino nurses, we came here, and then there was this whole concept of model minority by William Pedersen in 4 decades later. So that's this is 1960s. The sociologist coined the term model minority to talk about in New York Times Magazine, talking about this apparent success by Japanese population in the U.S. In spite of their internment camp history in the U.S. To their sound work ethics and genetics. So that portrayal of Japanese became a greater, the more generalized concept for East Asian and then, greater Asian population. So, I still suffer from model minority myth. And then there was around the same time in a Moynihan report, problem minorities, the Black population were portrayed as the problem minority, and then they were pitted against the examples of model minority Asians as to how model minority people are able to overcome certain disadvantages, and they made it to be this model. But then the Black population was a problem, and they have like a crack epidemic and such, and they are being the problem. So that what that did is we consider the white population as a racial majority, racial in-group, the out-groups, like we were pitted against. I say we because I'm an Asian, pitted against different people groups of color. So what that also did, possibly most importantly, is that it distracted the fundamental problem of structural racism being the reason for this problem minority to have been created to begin with. So this Black-white disparities that we have experienced, that we've been talking about all this time, have been distracted by this model minority versus problem minority. So you might remember early 1920s LA riots, Korean population in LA and Black population really getting into a major civil unrest, and then there's all other groups of color got their communities got damaged as well along the way. In the last decade and a half, or maybe 2 decades or so, this conflict among ethno-racial groups, so like say Asian, East Asian, or Koreans, and then Blacks and Latinx groups, we call that as a new fault line. So it's like a different kind, different set of racism we're talking about. And and then like whose trauma is bigger, like in the BIPOC group, who is included, who the Asian hate, the anti-Asian hate crimes, is that should we talk about that when there are other George Floyd just happened? These different racial traumas that we end up looking like we're competing, whose trauma is greater. It's like we call it trauma Olympics. But that is aside from, that is not the point at all. The point is, it's a greater spectrum of structural racism based on racial capitalism that we've been experiencing. Of course, it's bookended by, most prominently by, Black-white disparities and conflict that we have been talking about, but all other colors, if you will, in between. We're all this is from the same fundamental context and reasons. So I guess we'll get into the recommendations we made in the paper. We try to be very specific.
And so we've talked quite a bit, so we're going to try to go into some of these recommendations that we came up with, and maybe during the Q&A, you can present some of the ideas that you might have as well. And so thinking from a very local example or a local orientation, we can be thinking about how we're going to be investing in our public goods, namely thinking about public health as our public good, and for that to be a key element of our future. We're gonna depend on this kind of investment in order to progress as a country, right? We may want to be thinking about investing in our independent and robust state and local health departments. I think Robin and I come from kind of almost diametrically opposed kind of models, not quite, but from a New York versus a Florida orientation. I think there's different ways in which our health departments may or may not be independent from political structures and are differentially able to respond to needs. However, I think what is clear and shared is that the local and state health departments have been able to invest and delve into the needs of our particular communities and be able to be held accountable for those actions. So they hold kind of more direct and stronger relationships with community-based organizations and are closer to the need. I think also in terms of thinking about federally, we can think about a more well-resourced and politically neutral CDC, which we've seen in previous times, with a non-appointed head of the CDC, for example, whose mandate, mission and mandate and leadership extend beyond specific presidential administrations. I think it's important for us to see that as a public good and not as a political good necessarily, right? And then I think investing in Medicaid, healthcare for all, and then I think specifically thinking about the Indian Health Service. And I want to backtrack a little bit and say, this country was not, did not belong to all of the people, a lot of the people that we've been talking about today. This was the native home of Native Americans, right? So it is kind of bizarre that we have the kind of funding structure of the Indian Health Service that we currently do. And we can't talk about kind of dismantling structural racism and allowing for access to healthcare without talking about fundamentally changing and transforming the Indian Health Service as well. In addition, investing in workers' rights has been particularly highlighted through this pandemic. And I think we need to be thinking more broadly about ensuring safe work environments and what exactly is OSHA, where's their responsibility, where does that begin and end? And how do we mobilize for an independent OSHA, supporting more generally broad scale labor organizing efforts.
And the conversation we've been having about social determinants of health inequity, really getting to the root causes of our inequity, is possibly by transforming the environments and policies that produce inequities to begin with. So, the more proximal we go, the more individualized we become in investment. And we argue that it's actually much more expensive and less successful in actually keeping people, individuals healthy. The more distal we go, more systematic and structural we go, it's also going to be more economical, economically efficient. It's going to take a little bit of time to get there, but really transforming what is at play in terms of our structure is our recommendation. And also related, investing in our public infrastructure to produce quality public schools, social services, and behavioral health specifically, rather than investing in inequitable and punishing focused prison industry, which gets very expensive. Public infrastructure that is to get an intergenerational life course, health and wellness. So invest in our children first, all the way to the adulthood.
And so I think we have to concentrate specifically on the ties that bind us. So we have to be coalescing around a collectivist approach to public health policy or public policy. And I think we have a lot of points of commonality for mobilization that we can take into account the inequities that we have experienced thus far, but have an upstream, broad scale transformation that can really delve into a range of different outcomes and make our society overall more equitable, and in turn, more structurally sound to be able to deal with another pandemic, for example, or whatever else is on in our future, right? Whatever is on the horizon. So we have linked fates, as different diverse communities. And I think that there is a kind of, we're presenting a somewhat idealized version of how we want this this country to be. But I think there is an opportunity for us to get closer to that direction with more thinking about equity, thinking about engagement, thinking about inclusion, and not shying away from conflict and from inequity, but thinking about how we make greater investments in shared public goods and better wages and benefits for the least advantaged workers, and taking those kind of systems of oppression into account, and little by little picking at them and dismantling them. And furthermore, I think that what we're really trying to say is that if we don't plan for equity in mind, thinking that from that, not just from our current standpoint, but from a historical standpoint, we will default to inequity. So we hope that we have presented not only the history, but also a vision for the future. Thank you so much.
Dr. Moon, Dr. Bailey, thank you. This has been an incredible conversation and has just now made me, there's lots of claps, lots of applause in the chat. I want to invite folks to please, if there are questions or comments, to either raise your hand or put your question in the chat, because we'd like to open the floor for those conversations. I see we have a question here from Ms. Cohen. I will ask you to unmute. Sylvia, yes? Sorry, we're trying to get her to, Sylvia, you can unmute.
Yes, thank you very much. Dr. Deborah Levine and all the doctors who presented today. Now I'm reading your presentation, your paper, and I will live in Harlem. And now the question I have is, well, you mentioned the question of institutional racism and segregation. Now, the problem that we face in Harlem is that if you look at the indicators of community health that the city uses, all the indicators are not reflecting what you call the social determinant of health, okay? And they are not reflecting all the environment that is around health. But when we read, for instance, a policy paper from the American Society of Addiction Medicine, the first introduction is that overdose prevention sites are located primarily in high drug use areas and serve marginalized and hard-to-reach population facing barriers to good health and or safe living, including people who engage in sex work, etc., homelessness, housing insecurity. But there is an assumption here that you are doing good when you pack services. I'm sorry, I'm trying to okay, anyway, I don't see you on my screen. Anyway, the point is, how can we have a measurement of what is not an unsafe living condition? How can we have measurement of a racist health policy? Because the statement made by this particular institution for me is totally indicating that there is a packing on overpacking, if you like, or perpetuating a concentration of poverty, by packing. You make an assumption people need it, so the definition of need itself is biased, because it's really pack. Okay, let's pack it even more. Let's add more to already vulnerable environment. So we need to counter the discourse by measuring communities, but not just by individual, overdose deaths, etc. Not only with individual indicators. What are the indicators that can help us establish ratio of equity at community level, at local level? I know that in your first presentation, you had great maps, and you did already again, showing, disparities among neighborhoods. Well, we need to put that not just with maps, but with indicators that talk to decision makers for looking at the definition of needs in terms of social determinants of health. I mean, I'm trying to articulate something. You get what I mean, is that what are the indicators of institutional racism in the health sector? And what are the indicators of unsafe living conditions, in the neighborhood, in terms of what's a safe environment, for instance? When you pack different drug sites, is it a safe environment or not? So are you adding more to unhealth, or are you adding health? Okay, you get the idea. Thank you very much.
Yes, thank
So
you.
I
Give
think-
them an opportunity to answer. Thank you.
So I think that there is a kind of, I think this is a complex question and something that we're really dealing with when you're talking about locating services where they're needed. And I think there's a multifaceted kind of situation at hand. I think number one, with regard to some of the indicators, I think it depends on who is putting out the indicators, what is actually going to be shared. I know, so in my previous life, let's say, up until 2017, I worked for the New York City Health Department. And what we were trying to do was really develop out these community health profiles. So thinking about community districts and not just having those like kind of blips in the healthcare outcomes, those things on the farthest right, but also thinking about social determinants of health and how to organize those in different ways such that you're able to think about social determinants of health and to a large degree, social determinants of health inequities. So I think there's a concerted effort. Whether that's really translating is another story, right? So that's an opportunity. I think in addition, when we're talking about specifically drug treatment facilities, I think that it's important to, yes, have drug treatment facilities in areas that may be experiencing higher levels of overdoses, but the thing is that it does need to be spread out further, or else you are concentrating certain resources, and there's a kind of stigma. And that doesn't mean that people are using or live in those particular areas where you see the overdoses. So there's multiple things at work, and I think we'd have to delve into it a little bit more. I think what we do see is that there's a number of people, we get into Nimbyism, right? So not in my backyard, right? And so people who are able to advocate and have the power to advocate argue for drug treatment facilities not to be in their neighborhood, not to have a different shelter, whatever it might be in their neighborhood, right? So I think that's a larger thing for us to be combating and thinking about.
There's a question about classism.
Yes.
You want to address that?
Sure. So I'm seeing Stacy Plichta thinking about discussing more about classism, so that there's a divide and conquer that it applies to dividing the poor by race, by ethnicity, race, color. How should we, or how can or should equity efforts include the impact of classism in general, and specifically seek to include poor whites in the discussion? And I think that was part of what we were hoping to get into with the racialized drug policy case study. It's not to say, oh, well, whites are doing fine, and that's really, we need to be talking about how racist this narrative is. It's saying the narrative has been racist, but we share a lot of the same experiences stemming from a racialized classist society, and we are sharing some of the burdens and the negative impacts of that society, right? So it should be a form of bringing together a form of commonalities between us, that we're experiencing a system. It's not that each individual group is particular and they have an inherent difference in who they are necessarily, right? There's lots of heterogeneity. It's that we are experiencing very similar impacts of our neoliberal racist system. And we need to be attacking those things collectively, mobilizing together in order to address those issues. Okay.
Anupa, we will just go down what's in the chat and please jump in, and anyone, everyone. Anupa is asking, it's a great question, would love to hear more about what kind of structural interventions are happening in public health and allied fields, such as social work and education, to address upstream political determinants of health, such as power building, policy advocacy, political representation to co-governance, all great examples. Great question. I would say, well, actually, we're part of this work that, with Robert Johnson Foundation. There's a great initiative called the Culture of Health, and really recognizing community engagement and community organizing and power building. Who has the power to, make change in our society and improve health, and who should be the actors, who should be at the table, so to speak, and identifying the process and methods through which the power can build for the communities and individuals in it. The effort has started. I wouldn't say it's been around forever. The effort has, I would say, a decade or so.
Well, I mean, I think it depends on how we define it. So I think there has been power building of what you mean, culture of health specifically about. Yeah, I would say around that time. Yes.
But, we can go back to, MLK Jr., right? And the whole campaign, Poor People campaign, that's also being revived right now. But, we do have cultural and political legacy of, community-driven work. And like I'm saying, that's being, some of it is really being revived through the pandemic. That's one of the human progress that we see and we are encouraged by this pandemic time to see. But to link health outcomes and the processes to these structural interventions has been happening. It's not that we've been devoid of it. I think that us all together recognizing the structural racism as the most distal cause of our great disparities in our society will only propel our movement forward.
And I will add that I think that essentially there has been a growing kind of mobilization and thinking about it more specifically of how we kind of marry maybe some of this kind of like academic community with, broader social movements where they're not divorced from one another. So I think there's a larger argument around ivory towers and, even like the private intellectual enterprise to prevent them from us being separate from necessarily social movements, which are historically how we've brought about structural interventions and structural change. There's been a push or a pressure that needs to be put on different actors, namely government actors, key private actors, but we need to be able to put the data as a part of accountability, but being able to use that information in ways that maybe we can't do from an academic standpoint, but really is talking about what are people experiencing on the ground and linking those structural things to everyday life. Yeah.
I see that Dr. Stokely has a question or put in the chat. I see your premise as the reason for placement for excessive amounts of drug treatment facilities in Harlem. Do you agree? So I don't know who wants to respond to that. Dr. Bailey, I know you have not been in New York in a while, but if you want to speak to that, you're welcome to.
I think that refers back to the previous conversation that we had, where I think there is a premise, there is a reason for some of the excessive amounts of drug treatment facilities in Harlem. I think that there is a question of a Nimbyism, which is rooted in, so not in my backyard, which is racialized, it is classist, it brings together who has power, who doesn't have power, or varying levels of power. So I think that has been a key issue in terms of who can mobilize in order to fight off certain things. So if we think about gentrification and different forms of development, I think that there's different groups or different communities have been able to mobilize together throughout our history as in cities to be able to kind of collectively decide what needs to be in a particular area.
It's not that different. This phenomenon is different from like bus depots going up to the Bronx and chemical incinerator facilities going to these more actively disinvested area. I think it's not different.
And I don't know if Dr. Stokely had any further questions.
Yes, I think she's unmuted.
Yeah, thank you. Thank you for the doctor title, but that's not there. I didn't work hard. Some of you have, so I don't want to absorb that title without all the hard work. I would love to award it. So, but thank you. What I hear what you're saying, and I understand that often the default is that is the Nimbyism. But I think what has happened in Harlem, at least in the particular concentrated area in which I have lived for 70 plus years, is that the lack of power has allowed the power structure to continuously bring things into our community because they knew we did not have the political or economic clout to fight it. And so now after 50 years of this, we are now at a point in the near 125th Street, Lenox Avenue area where the services are so concentrated that it's impacting those of us who are not addicted to drugs with the fallout that happens when you bring this heavy concentration of this service into a community like this. For example, the drug dealers know they have a nice market, so they come to the area. And then the services for those people who need service, the social services that should be wrapping around these people are not there. And so they find themselves wandering in the streets and engaging in activities that's unhealthy for them and for others. So this is impacted on other people's mental health because of what you feel when you encounter that. You feel the compassion for these people, but you also are saying, but I don't want to have to live in this space. So I see that structural racism has allowed this to happen in our communities. And so that was my point. And so part of it is NIMBYism, absolutely. But another part of it is that I have lived here all my life, and I'm not going to apologize for wanting a certain quality of life. And I think this is impacted on that. So thank you for your report. It's very interesting, and I appreciate it.
Absolutely.
Before the two of you respond, I want to just give Tracy Gardner an opportunity to put her question forward and then, or her statement forward, and then the two of you can close out if that works. And if there are more conversations and more questions, we'll be happy to share those with both of you, and we can continue that conversation if that's okay. Tracy?
Hey, good afternoon, and I apologize for joining late. I found out about this late, but I certainly would have wanted to be out in the beginning of the conversation. And the only reason, well, not the only reason, but one of many reasons I am especially interested in this discussion and the impact on Harlem, having been a resident for a while, having worked with service organizations there, having worked with Deborah Levine, where back in the HIV days, we were able to make a determination about the upper greater Harlem area not getting enough services and funding to respond to HIV. And so, that needs to happen. And the way that we were able to mobilize is to create a table, if you will, to have a discussion that coordinates information, that really kind of brings the facts to the table versus the emotional responses. And by no means am I dismissing the concerns of residents of Harlem, new and long time, about what is going on. But we should be clear, a couple of things, which is what you were talking about earlier. Racialized policies, from the war on drugs, whatever you want to call it. But we, as Black people, as predominantly Black communities, when we are dealing with these kinds of issues, we have taken on the criminalization. And there can't be planning for the health of the community unless it acknowledges that people who use drugs, people who have chaotic drug use, people with serious mental illness are part of the community. And so if you did a kind of data scan, you would know, for example, there aren't a lot of OMH facilities or services in the area. And a lot of the people that we're seeing have co-occurring disorders that drug use exacerbates or is a primary issue, but we're talking about like 20th century systems and structures to address a 21st century problem. And Harlem in particular has not been able to get the attention of government, get the attention of electeds to say we need a comprehensive response. We've been funding in silos and in fragments, and we're seeing the results. And again, I say this as a person who has deep ties to the area. And in 2016, when I was working for the governor's office, this became a political problem, and I was dispatched to a conversation in the state office building where everybody was at the table to talk about what was going on. I put the quote into the chat because I feel like unless that's grounded in fact, it's inflammatory, and it creates a hostility and very little possibility to go to solutions rather, and instead really makes it easy to villainize the people who are there and who need services. So while there is, and again, that term oversaturation, oversaturation and too many concentration of services, be clear, our policymakers, our electeds, our community leaders on some level, at some time way earlier than what we're dealing with now, said this was okay. It was like at a time when Harlem wasn't so cute, and they were the folks who would pay the rents and would restore the buildings that nobody was taking care of. So this isn't a new phenomenon, clearly, but it is definitely a phenomena that needs a more contemporary response. And I think that we are clearly seeing where the approach to people who have drug problems and people with serious mental illness has been rooted in policies and approaches from like medieval times. And we've got to bring it current, but the community needs to say more than just these people and these programs are, we're dealing with an unfair burden, right? Because many of the people live there. They've been or they don't live there anymore, but they still have attachment to the community, or they've been displaced. And so, and there are people coming to access services where Nimbyism has been able to be effective. Long Island, Staten Island, I mean, even like upper parts of the state, people are coming to Harlem because yes, it's where the drugs are and where people are, but it's also where the services are, because other places have been quote unquote successful at keeping these services out. Sorry for that long diatribe.
No, but that's really helpful, and I'm glad that you brought it up, because I think it's what it's saying. I think in continuation, I think there's a essentially, if we think about that kind of upstream downstream, you can't just like concentrate all of these treatment centers in one location in Harlem without also thinking about the other upstream factors that we're not really getting to. So like that, it's an inappropriate response. It's an incomplete response. It's not taking into account what is actually going on. So I think there is a combined element, and where oftentimes people are going to be, they're stigmatized, they're stereotyped, and there isn't that connection to a larger social determinants of health and social determinants of health inequities. It's a treatment center, full stop, right? I think that there's ways that we can be thinking about this more systemically. And yes, there were previous, there's a reason why we are seeing the patterns of, drug use, et cetera, that we're seeing, and we're not addressing those issues, right? Like we're not addressing those kind of root causes. And so essentially we're getting into an argument in a way that it's detracting from the real root causes of the problem.
Thank you so much. I know that we've gone over. I wish that we could extend this conversation, and hopefully both of you will be willing to come back, and we can have more of these conversations. I think we have a lot of work to do, and there is lots of room for taking the data we have, expanding the data that where we don't have the strongest, but also making sure that we have a table that has all of the parts of the community at it, so that we can really begin to turn the tide differently. I can't thank the two of you enough. If you have a closing statement, I'm happy to give you space to do that. But again, for folks who have joined us, at the end of this, you will receive a link regarding this live webinar. We're happy to take additional questions. And if there are other conversations that you would like us to have, both for the Village of Harlem, the City of New York, the State of New York, and beyond, please feel free to send those to us. And we will continue to have this open dialogue, looking for solutions and not just looking at problems. So I turn the floor back over to you for any closing remarks.
So we're not going to take too much more of your time. We just want to thank you for your attention and like really engaging with this material. And I think really thinking through what are the solutions in Harlem, the Harlem context. What is the solution, right? So I think I hope it's stimulated you in a way that you're able to continue this conversation, not just with us, but with others. And, thank you so much. And thank you so much, Deborah, for having us.
Oh,
Thank
it's
you for having
been my
us.
pleasure. Sorry, Dr. Moon, go ahead.
I just said thank you. Thank you for the opportunity. I have been a long-time resident of Harlem as well until very recently. Harlem is very close to my heart. And that's the reason why I teach at CUNY School of Public Health. So hopefully I'll be back. We'll see you soon.
Yes,
Thank you.
thank you.
Thank you. And again, happy holidays to everyone. Thank you very much for coming and participating. Know that this will be part of our YouTube channel series, so you'll be able to share this with your colleagues. And again, thank you so much for your time, your energy, and your talents, and for participating and being a part of this conversation. Thank you again.
Bye.
Bye.
Thank you. Thank you.